HCC. This brings me to another component that I would love to hear also the international perspective on. And if anything, we always talk about multidisciplinary management of HCC, because at the end of the day, it's two problems: the cancer and the liver disease. Tell us, Dr. Kudo, how does it work in Japan? Like, how do you meet or how do you interact in regard to different disciplines?
Yes, in Japan it's a little bit different from other countries because hepatologist, I'm a hepatologist does radiofrequency ablation and TACE, and of course interventional radiologists also perform a TACE, and systemic therapy is performed, is done by hepatologists, and because there's a few oncologists in Japan. So of course, we have a meeting with a multidisciplinary meeting with the surgeon and the radiologist and the hepatologist. That we have in my hospital. There's no liver cancer specialized oncologist.
I have to say, this is really impressive. If anything, you know, it's not really Japan, it's also specifically you. You're amazing. I mean, like, you know, you really have a lot of expertise in all of those disciplines per se. But let's see, what about on your part? Like, you know, how does it go in Germany?
So I think, I mean, if you ask an oncologist or a hepatologist or anybody who treats HCC, I think everybody will most likely say that all decisions are made by the multidisciplinary tumor board. Yeah, so I think we all agree with that. So I think it's more the question maybe we have to address more is on the quality of the multidisciplinary tumor board. And I think this is really important, and I think we really need to make the point here that if we discuss a patient, all disciplines that are on the table needs to be somehow experienced or expert in their respective fields. I mean, if you do not have a good liver surgeon, it's really difficult to discuss liver surgery. Yeah? So I think this is an important point, and this is also one of the reasons why I still think, specifically in the beginning, I mean, these patients really needs to be discussed in a tumor board where we have very experienced colleagues. And the other point is, they should not only be discussed at the beginning of treatment, but also later on. I mean, once you have done a treatment, I mean, you need to decide whether you can continue, whether you need to switch treatment, and how long you do any specific treatment. So I think this is two important points. First of all, the quality of the tumor board, and then that you really need to repeat the discussion while you're on treatment.
Fair. Yeah, actually, you bring a very important point. I'm going to touch it again when we talk a little bit more about staging. But let me talk or ask Rich. Tell me about, I would love to go to hear about UCLA's, you know, multidisciplinary management of HCC. How does it work?
Well, we do, as Arndt commented, we do have expertise in these areas. We have and it's not only biliary surgery, it's actually having a transplant surgeon, right? Because transplant plays such an important role. And having interventionalists who are experts in their field, whether it's just percutaneous or TACE. And so we do get together about every other week and we review the cases, generally the more challenging cases where there's more doubt as to what is the best thing to do. It's just not practical to look at every single liver cancer case, especially when there are clear guidelines where there isn't really that much of a question. You know, a patient's well compensated, has a tumor that can be resected, that patient should be resected. A patient has extrahepatic spread, that's clearly an advanced patient and needs systemic treatment. But we do have lively debate for those gray areas, because in reality, in liver cancer, and as we'll probably discuss over the day, there are areas where there isn't data, right? When there's data, it's very easy to make decisions. It's where we don't have clean data that expert opinion and resources come into play.
I hear you loud and clear. If anything, we're going to talk about staging. And interestingly, that in BCLC, if we were to really call it white and black in regard to what we're looking at, the gray zones are really the problem, the in-betweens. And you're absolutely right in that regard. But if anything, we can see here that maybe, yes, we differ across the different countries, different continents in regard to how we do the multidisciplinary team. But I think the spirit is still there because, as we heard from everybody, understandably, that we take the opinions and the views of the different expertise to make sure that all the necessary inputs are given to make sure that we deliver the right care for the patients. If anything, I refer here to a beautiful paper that was written by Hashim al-Sarraj a while ago, where he pretty much said that patients who are seen by all the disciplines are the ones that will do better regardless. And this is really will again focus about the need for the multidisciplinary team per se.